Hi, this is Naimuddin Robi. I'm currently doing Masters in Rehabilitation Science at McMaster University under the supervision of Dr. Lisa Cardoso. My poster presentation is about validity of central sensitization inventory through rush analysis in patients with knee osteoarthritis. It is found that persons with knee osteoarthritis have evidence of central sensitization demonstrating hyperalgesia at local and remote sites. Central sensitization is measured by psychophysical testing and patient-reported methods such as central sensitization inventory. There is a poor agreement between values from psychophysical tests and the recommended CSI cut scores. Basically, the CSI was developed subgroups of people with chronic pain, but not knee osteoarthritis. So evaluation of the validity of CSI may help our understanding of central sensitization in patients with knee osteoarthritis and provide a clinically feasible measures of central sensitization. We use rush analysis, which is a strategy based in item response theory. The main key assumptions are the easier item on the scale, the more likely it is that respondents will obtain a better score on that item. Respondents with more of that trait of interest are more likely to obtain a bigger score on any given item. The key approaches of validations are model fit, unidimensionality, Partial separation index, differential item functioning. The purpose of this study is to evaluate the validity of the central sensitization inventory through rush analysis in patients with knee osteoarthritis. We use rush analysis to identify and subsequently reduce the risk of bias in central sensitization inventory by identifying and addressing differential item function, and also to explore opportunities to optimize a clinically feasible and robust surrogate measure of sensitization. This was a secondary analysis of cohort study where 293 participants were recruited from 3 university-affiliated Montreal hospitals, and all the participants were aged over 40 years and diagnosed with knee osteoarthritis. The main variables is 25 items of CSI, and the person factors are age, sex, BMI, knee injury and osteoarthritis outcome score, numeric pain rating scale, pain catastrophic Zane scale, pressure pain threshold, temporal summation. As the result, we found that the mean age of the participants were 63.6 years, where 58.7% were female, and almost half of the participants were obese. And the mean CSI score was 30.8, which indicating lack of central sensitization, as the CART score is 40. Response distribution across the scoring options for all items indicated floor effects of on at least 8 items, and 50% of the participants scored 0. The initial evaluation with rush modeling indicated misfits. We found 11 out of 25 items on the CSI displayed disorder thresholds, indicating lack of discrimination, and those items were rescored by collapsing response categories until the threshold demonstrated subsequent levels. After the reanalysis, it demonstrated persistent model misfit, so we developed a subtest to address local dependency of 6 items. After this correction, we achieved model fit and unidimensionality. Only one item, frequent urination, which is item 21, showed a pattern of uniform differential item functioning by age, which was statistically significant. Finally, we can conclude that the CSI was able to be fit to rush model after rescoring while retaining all 25 items. Floor effects are seen, potentially due to a lower prevalence of central sensitization in this sample. The users of CSI should be aware of potential for differences in scoring across age groups for frequent urination item, and the unidimensionality validates central sensitization as measured by central sensitization inventory as a singular constant. Thank you, everyone, and thank you to all my supervisors and the funding organization.